we provide it to everyone free of charge. And I hope that you will all benefit out of this. I work in Essex. You can see it on the map there, just next to London and Hertfordshire in the United Kingdom. And this is just where my hospital is. And I also teach in this university called Angela Ruskin University. We are, as iHistopathology, we are a non-profit organization. And thanks to you and to your support, we got the Clinical Excellence Award from the Royal College for the Yearly Achievement Award last year. And this is basically just basically a thank you to all of you, not all of us. Today, I'm going to give a macroscopic stations and how you will deal with this in the real exam. Some of you might have sat the exam before and you already know. Some of you might be sitting the exam for the first time, as we saw from the questionnaire that we've sent with the registration. So for those who already know the information, maybe nothing will be new for you, but for those who are new for the exam or going to sit it for the first time, there will be an important things for you. And for the macroscopic station, I like to call it the art of imagination. And you will understand toward the end of this lecture why it is the art of imagination, because of what you will see in the next few minutes. And I'm not going to waste more time into this, so we will directly take you to the first case. And I will tell you the setup as we are talking, so you will understand how that will work and how it will function. Now, this is a pancreatic odontectomy, and it is a cancer head of pancreas specimen. And you get on the sheet of paper together with the picture of the specimen, you will get a potential questions that you will need to brainstorm around these questions before you take the sheet and enter into the station to present the cases. So you will be given the four macro, and then you will be given time approximately around between 20 and 30 minutes, variable. But you will have to brainstorm what are you going to do about those, and you will have also a booklet that you can write your thoughts. You are not going to be marked for what you will write in the booklet, but the booklet is only to help you when you go inside the station. If you are one of those people who panic, then ideally I would recommend that you write your this is what I'm going to say first, second, third, fourth. Then you can put the booklets in front of you and read from it. It is a good idea as well to write your cassette index in the booklet, so you don't have to sound like a haphazard person trying to recall back which block I'm going to take. Oh, I might take this block, I might take that block. No, this is not going to function or look well inside the station. The problem that this is not a problem. The things that you need to realize that you have 4 cases to present in 4 minutes, right? And you need to answer some of these or the 3 questions that will be linked to the specimen. Sometimes there are 2 questions, sometimes there are 3, but they're usually around those, describe the specimen, how would you deal with this specimen, list the block selections and give reasons of your block selection, what are the main prognostic parameters for tumors in this area, how do you grade this tumor? How do you state this tumor? So these are generic questions. You should know these questions, of course, before you approach this station. So these are the standard questions that you will get nearly with every specimen. So this is just a thought process when you revise. So it gives you a skeleton of what you really need to prepare. Now, this is not your FRCPath certificate yet, but hopefully you will all get the certificates. But the reason why I'm putting these pictures, because this is how you should look when you sit in front of the examiner. First, you should look happy, like as happy as this gentleman here, smiling, okay? But you should hold the case which you are going to present to show it to the two examiner who's sitting on the opposite side of the desk. Okay, so there will be a desk between you and the examiner. So you put your booklets open into what you've written in front of you. That booklet is for you, not for the examiner. What you've written before you enter the station inside that booklet, it's for your thoughts of ideas, okay? But for the examiners, ideally, you should hold the picture which you are going to talk about exactly in that way. And this is the way that I would like you to practice. So you sit, so tonight and tomorrow, you go and sit in front of the mirror, print a page of a picture, and just sit in front of the mirror and see how your body language moves, how you will be able to point to the picture, the various areas. And because the examiner needs to see what you are trying to talk about into the specimen. Okay, so the examiner will need to see that and what you will draw on the pictures, because you will be given a 5-colored pen, and these pens will be can be used on the laminated paper sheets that has got the picture of the specimen. So you can annotate, you can draw your blocks, you can make arrows, you can do whatever you like on the drawing, but then you will need to show the examiner this. So your drawing has to be neat and has to be very well organized and sharp, so the examiners, the two examiners, can see that clearly, and it will help them to understand what you are trying to say, even if you have got a stutter or you are worried and you cannot explain yourself properly, but you will be able, the drawing then will help into that case. So this is one of the practices that you really need to do, and you need to do a lot of it, right? So don't worry, you can close the room, lock it, sit in front of the mirror, do that day in and day out, and then come back and have some juice and go back again. So this is the first case that we were talking about, and this is what you get. You don't get any more information apart from the name of the specimen and nothing else, right? So basically, what you then need to apply, how you will deal with this specimen, how you will take a block from this specimen. This is the thought process that you are putting into this before you enter into the exam station. One of the very difficult scenarios that people face is you give them a picture like this under pressure, and you ask them what's anterior and what's posterior, right? And well, a lot of people usually will know what is anterior and what's posterior, but believe it or not, that some people get very confused in the directions and they mix it up. This is a very big mistake in the exam, okay? So if you cannot define what's anterior from posterior for your specimen and what's right from what's left, then you are heading towards a failure in that station. And despite what you are going to say next, you might actually have failed yourself in the first spot. I remember a few years ago, I was doing my driving test, Yes, just a driving test. And I failed the driving test in the first second. Okay, because as soon as I was coming out from the driveway with the car and the examiner just sitting next to me, I didn't look properly into the side mirror. So I spotted that, but he spotted that too. So when I got the feedback, he said, yes, you failed in the first second. And this is the problem, that if you cannot define the structures properly, or if you cannot define what's right from left, anterior from posterior, then you kind of like, no matter what's you're going to say, you have failed, because there is no excuse for a pathologist not to be able to identify the anatomy and the directions correctly. This will lead inevitably to a disaster. And I have seen people failing, not in this particular one, but they fail on just not being able to identify what's superior from inferior, what's up from below. And don't forget, you don't get it orientated like this is up and this is down. I might, you know, if you turn this picture 360 degrees, then or 180 degrees, you will see it upside down. And the picture doesn't tell you what's up and what's down. So it is up to you to orient the sheets. And it will be a good idea if you wanted to write on the specimen what is right, what is left, what is caudal, and what is or what's cranial and what's caudal ends. So you can then it show the examiner that you understand how you orient this specimen, how you put it in the right anatomical position. So this is quite important. The other things as well, some people always ask me, should I start by saying I will confirm the type of the specimen with the specimen pot, confirm the name, the hospital number, the date of birth, blah, blah, blah. Yes, okay, right. But don't forget, you have only 2.5 minutes to present this case and score the maximum score. So for 2.5 minutes inside that station, you need to be precise, sharp, know exactly what you wanted to say in order to score. Okay, so if you would like to say, after identifying the specimen against the patient details, that's enough. Yes. I will make sure, and this specimen ideally should have been opened prior to dealing with it. So you can briefly, within 10 seconds, explain, I'm going to open it in the anti-mesenteric border for the duodenum, and the pancreas will stay intact. Okay, so this is what you will say. So you're only opening around the bowel, rather than, but you don't open the actual pancreatic specimen, right? So because of how you're going to deal with it or cut it, and I will show you that in a minute. But this is just a quick tips to how to escape these areas. So you can say, yes, ideally we would open the specimen, leave it to fix. You can say how you're going to open it, so that will give a good insight to the examiner, that you have a good introduction, and you also have got the tensions out of starting into this specimen. Okay. And then the other things as well that I wanted to say, we will come back to the specimen in a minute, but this is the real area in the exam that you really use the data set. Because a lot of people say, oh, it is boring, I spend a lot of hours, I cannot recall it back. But this is the area where you really apply your data set into the FRCPath exam, okay? And this is why we always advise people that in the last 10 days before the exam, you should have quickly just revised what you've marked on the data set quickly, in order to just be in the top form. So don't just say, yeah, I read it 2 months ago. Ideally, this should be revised a week before. A lot of the data set items are not important, especially in the introduction bit, but you only need really to focus on the core and the non-core data items and the specimen handling and the block selection. So For almost all of them, it is just the central points of the data set that are important. The rest are just a lot of things that you don't have to worry about. So for that particular specimen, for those who would like to know how you open it here, this is just only from the data set. So you ideally, you should leave it to fix before you start cutting through, because it can be very friable, especially the pancreas. You know, it's full of fat, it can fall apart. So you should really leave it to fix. Don't try to be brave into that. If you have a stomach included, you should open also the stomach along the greater curvature and the duodenum around the anti-mesenteric borders. And in every data set, you will have this area, which is the gross description, how you describe the specimen, really, yes? So you should describe the type of this specimen, right? What are you seeing, really? You know, like, are you really seeing a pancreatic duodenectomy? Is it with a pylorus preserved surgery, or do you have the pylorus included into this? Do you have a jejunum included into the specimen? So you should really try to work out a little bit of the anatomy, and I will come back to this specimen in particular in a few seconds. But you should also, the classic descriptions, which some people refer to it as the size shape of this tumor, the surrounding of this tumor. You know, you can use this S rule that we teach for our medical students, but you also need to focus a little bit on special things that might be related to this specimen. Don't forget, the examiner expecting you to comment, for example, on the resection margins if you can see a tumor. If you're getting a wide local excision in a breast and you can see the tumor, you would expect to comment on this. So try to remind yourself with the name of these procedures. So there are Whipple's and pylorus preserving pancreatic duodenectomy, for example. These are names. Try, if you don't know the anatomy of a certain area, you just make sure that you know it. If you don't know, for example, that in the pancreas, toward the inferior border, the vessel is called superior mesenteric vein. And when you go toward the top of the pancreatic specimen, the name of the vessels changed to become the portal vein, then it was considering this, you see, because the examiner might, if you have the vein included, they might point to you into a structure and ask you, does it happen that you know what is the name of this vessel? And it will not look right if you don't know the name of the vessels, if it is relevant in this particular specimen, which is the pancreas. So you need to have a clear understanding of the anatomy. And if you don't know, please go back and just open an anatomy book, because you need to know where is the duodenum, where is the pancreas, where is the uncinate process, where is the gallbladder going to be in relation to this specimen. And the other things that a lot of people, when you start taking a block, they forget under the stress and the strenuous pressure of the exam, you tend to forget the inking process, especially if you work in a center that doesn't use ink. You know, in the UK, we almost always ink all our specimen. 99.999% of our pancreas of Whipple, we will ink those. And we ink them with preferential inks, you see. So you need to learn this. You need to learn that we ink the anterior surface with one color, the SMV groove, we ink it with another color, the SMA surface with another color, and then the posterior surface, we ink it with a different color. So this is how we ink the specimen. We don't ink the inferior aspect or the superior aspect. So for those who just will get confused, we include those with the circumferential inking. So we extended the anterior to include part of the superior, and the posterior as well goes a little bit to the superior and the inferior aspect. So we don't have a special ink for the inferior and superior margins, because for us, these are not margins into this specimen. But this is what you will get in the exam, as I have clearly told you in the specimen. So most of the time, you don't get the anterior view and the posterior view. You just get one view. And then I ask you to describe the specimen. So ideally, you should say, I identified in this specimen the duodenum with a stapled margin. You can see that, distal margin. And the pancreas, which is the head of the pancreas, basically, which is around there, right? So the duodenum measure descent length and descent width, and the pancreas, and you will give me the 3 dimension of the pancreas. If you have a scale next to the picture, like in the previous picture that I showed you, you can either mention it as the pancreas measure XY by Z, or you can actually give me the real measurement if you can look at the scale. And even with your hands, you use it, or with a ruler, you can use it, and you can tell me, this is what I'm going to do. So I measure it, and if I measure, let's say 15 centimeter, then just say it, because you will, in all the picture, you will have a scale next to the picture, and you can roughly know. We just think that it's a little bit laziness that you don't measure the specimen, right? And then I will color this specimen with a preferential color, and you have to say how you will color it. So don't give me headlines in the exam, okay? If you give me headlines in the exam, you get penalized, or you get asked, because the examiner will think that you don't know, okay? If you say, I'm going to ink this as per the local protocol of inking, no, you just have to tell me how you are going to ink this, right? So you ink the anterior surface, the SMV groove, the SMA surface, and the posterior surface, okay? So providing that you already do that, then you should be okay. And then you will say, I'm going to slice this specimen. So I will keep coming back to this picture, and we will keep building our story around it till you understand. But this is the inking, okay? So you can see this is just a side view of the specimen, which you did not see in this. But this is why you should be able to say it, right? I have the anterior surface here, and then I have the SMV groove, and I have the SMA surface, and then the posterior surface will be at the back here, okay? So this is our idea of how you will ink into the real specimen. And like any specimen in the body, you need to deal with the margins, okay? So the problem of the pancreatic or duodenectomy specimen that you have a lot of margins here. And these margins include, of course, the common bile ducts. It has got the small bowel from either side, so the proximal and the distal, or you might have the proximal as pylorus. So it depends on if it's pylorus preserved surgery or they sacrifice the pylorus. So, and you have the pancreatic neck. And then if you have a vessels attached to where they are supposed to be, then they also become margins, okay? And the only one that you don't have a margin for is the anterior surface, okay? The posterior surface, however, as you can see here, is a true margins into this pancreatic duodenectomy. The anterior surface have more of a prognostic effect, but it doesn't contribute as a proper margins that if a tumor is present, we don't say a positive margin. And these are clearly written in the data set. So this picture is from the data set. And this is the margin that you are required to make comments upon. And I will show you that again in a minute. But this is how we slice our specimen. So after we deal with the margins, and I will show you in a minute how we deal with these margins separately. So you have of course let me just use the pen. Here we are. You have this is your common bile duct margin. Sometimes you get the gallbladder separate, like in our specimen. So this will be sent separately. So you don't see it here, but we usually take it in the surgery. But then you might end with this area here that I'm marking that will become your margin for the common bile duct margins, okay? So this will be your margins here, or you might get the hepatic duct as your margins, which will be somewhere here if you have the gallbladder margins. I will tell you how we will deal with that surface in a minute, okay? Some people like to take it as a shave, but in most of the centers in the UK, we tend to include it in our horizontal slices because we tend to horizontal slice our sections from superior to inferior, and we lay down those slices in order so we lay down these slices in order, and then we number them so we know exactly where we are. So this is what we do after we slice. So you will have almost always duodenum in one side, and then you have the pancreas on the other side. And then the things is that what you need to understand that you will have this surface, which is, you can see it is the inked yellow surface. It is where your pancreatic margins and the pancreatic duct margins is. So because you are including this margin in nearly every block, so you will be able to clearly see it. So this is the margin that we are talking about here. And this is your pancreatic neck margin. Okay, and of course, in some of the slices, the pancreatic ducts will also appear, and then you will be able to. So this is why sometimes it's not important then to shave this margin, because you will still be examining it in every slice. And and other people who do the upper GI will tell you, okay, it's better to sample the entire pancreas, and this is what we tend to do. But you can, yes, sample the tumor if it's clearly visible. But the problem that you will face in a lot of these tumors, that they come after chemoradiotherapy and you don't see the tumor, so therefore it's bad. And the post-radiotherapy, you only get a residual multifocal viable disease, and the only way to see them is to sample the entire pancreas from top to bottom. So this is just to address and show you this way of how we will sample those. And then we go back to our specimen, and this is how I would expect you to do in the exam. So I would expect you to have your ruler, and with the pen that they will provide to you in the station before you enter, you should then mark or you should make your sections to show the examiner, this is what I'm going to do. I am going to horizontally slice these tumors into that directions because, and you might get asked then why then you are doing it horizontally rather than doing it vertically, which is not uncommon questions for in the exam. Are you able to hear me? Hello, are you able to hear me? Yes, good. Okay. So, and I just would like to double check again if you are able to see the pictures as well. Are you able to see the pictures of which I'm talking about here? Yes, good. Okay. So you mark this. So this is one of the markers that you should be doing. So I will take you back to the picture, and I just will I just would like to take you to the picture, which is we started with here. Yes. So the problem here, when you describe this, you described the specimen and you took the measurement, yes? And you said, I'm going to color it. I will horizontally slice it. What you didn't say yet, that you didn't describe for me the tumor. Okay, and this is the problem of this type of specimen, either a colorectal specimen that you've been given as a closed specimen, or a specimen like this, where you are only being given one picture here. Yes, only one picture of this specimen, and I wanted you to give me your imagination. Okay, so basically what you would say into a picture like this, let me just go and draw again here. So yeah, so what you would like to say, okay, I will horizontally slice this into from superior to inferior at a 5 millimeter interval. And on sectioning, when I see the visible tumor, I will see the maximum extent of this tumor. I will measure my tumors in 3 dimensions. I will say the relationship of this tumor to the 5 margin that I told you about. And I will see the relationship to the ampulla, to the pancreatic duct, to the common bile ducts, which will have an intrapancreatic portions as well as extrapancreatic portions into this. Okay, you will see if there is any invasions into the adjacent structures, and you will also see the parapancreatic nodal disease, which is usually, you will see it around the capsule of the pancreas. You see a lot of lymph nodes usually. And you will also, what you will also say, so this is what you should say. And this is why I started the lectures by saying this is the art of imaginations, because you still didn't describe for me what you are going to see, okay? But then the problem here of what I'm going to do now in front of you, that you need to have a ruler in the exam, because you don't want your lines to look like this, what I am doing now. Please, yes? Because under the pressure with a lot of adrenaline, this is how your lines will appear. Okay, so make sure, please, that you have a proper ruler. So when you do your lines, they are quite nice and neat. You can draw here around where your pancreatic neck margins, that you can exactly do something like that and say some centers would like to shave these margins with the pancreatic duct from the neck of pancreas, but some other centers will stain it and will include it in the horizontal slicing. Okay, I will deal with by my distal and proximal margins as just shave sections, and you can draw. Okay, and then I will, so this is, and then you tell me in the sheet of paper, in the sheets of paper which you have next to you, tell me the numbers. Okay, so what I did in my exam, I numbered the margins. Yes, let's say that you are going to deal, and then you have, of course, your proximal margins somewhere in the up, and then you number those as I showed you in the drawing, in the next drawing, and these numbers should translate into your sheets. So as you tell the examiner, basically, so let me just take you to the other diagram that we have it properly labeled here. And what you will say to the examiner, that I have my number one is the inferior most slice, number 2 to 10 is the sequential slices from the inferior to the superior aspect. So, and my A11 or block 11 is the superior most aspect of the specimen. Of course, you will need to show the examiner, you need to show the examiner, sorry for this, I'm just trying to drag this. Yes, you need to show the examiner also that you have awareness where you will find your common bile duct margins, which you will find it somewhere here toward the top of this superior aspect of your specimen, or sometimes you see it superior posterior aspect of the specimen. So you would tell the examiner, you put a number somewhere here, and you tell your examiner, so you basically do that. I'm just showing you exactly what you will do. So you will do this here, and you will say, this is, for example, number 14. This will be my common bile duct margin. Number 15 is my proximal large bowel margin. Number 16 here is the distal margins. And so this is how you will do it. And you need to be that like a bullet inside the exam. So after you finish the description of specimen and the measurement and the coloring and describe what's not obvious, after I slice it, I will describe the tumor, site, size, its relationship to the common bile duct, to the ampulla, to the pancreatic duct, and to the circumferential margins. And then I will take my blocks. Okay, and this is and my block index, as you are able to see on my diagram, between 1 to 13 is a sequential mega blocks that I will take from entire pancreas, from inferior aspect to the superior aspect, numbered as follows. I will take my proximal margin, my distal margin, and common bile duct margins, and then I will sample any other lymph node that might be included in any tissue that has been sent separately or included in this specimen, which we might not be seeing because there is a mesentery here. Okay, and so the data set, if you go down back to the data set tonight, they tell you in the pancreatic specimen, we sample all the fat. Okay, all the fat. No, so you don't only select nodes, no, you sample all the fats that included in the specimen. But this is the difficulty again, that you sometimes, if you don't say it, the examiner might ask you, is there anything else you would like to sample? And the problem under the pressure you might say, no, I think I have sampled what I needed to sample, but you forgot that you might have been sent a vascular margin separate, which usually is the case. You might have been sent other additional lymph node. There might be additional fat that you don't see in the picture here that you also need to sample it. So this is quite important because you don't, it is not all, it's not that I only describe what I see. No, because if you go ask this, I go ask that in the exam, I actually go ask that question in an nephrectomy specimen. What if there is anything else you will take? And the question was targeting, yes, I will sample I will search for lymph nodes and I will sample lymph nodes. Or I will check if there is any additional pelvic lymph nodes has been included, for example, in the nephrectomy specimen. So this is what people might get asked, and you get penalized because you miss on a big things. You see, they will say this is unsafe because he doesn't know the importance of sampling the lymph node, and then they might fail you in the station because you forgot to mention about the lymph nodes, which you are not seeing. You see, we know that you are not seeing it. Yes, that's not something that's coming out of nowhere, but imagination. Okay, you don't see the tumor here, but you still need to tell the examiner, I'm going to describe this tumor. And how you are going to describe this tumor after you slice is something that you have to bring out. Okay, it's not only it's the shape, the size. If this patient had a previous treatment response, do I see necrosis? All of these things I'm going to say. Okay. The other things as well that I in the next, which is the next level that you need to do into this specimen, if you can, is to say this. I'm going to take this sequential slices to see a post-treatment response. You are telling the examiner why, because you remember, one of the questions that I showed you at the beginning was, tell me your block selections and why, okay? And a lot of people, I find under the stress of the exam, they say, I'm going to take the sequential slices from this, and I will sample the entire pancreas. Okay, but you have to tell me why, right? It is not a common sense. In the back of your mind, it is, yes, it's a common sense. They know why I'm taking it to test to examine the tumor. No, it is what's common sense for you in the exam. It's a test of knowledge. And I would like to know that you have read the data set. I would like to know that you are going to look for this tumor. You are going to look for the main duct pathology, the small duct pathology, to see if you have, for example, an IPMN related into this specimen. You also examine this to assess the circumferential margins, which you have to name them for the examiner because it is a test of knowledge. It is an FRCPath exam. And you say, I'm taking also this block to look for things like the proximity, the direct invasion to the duodenum, the relationship to the ampulla, as I said, the perineural, perivascular invasion, extrapancreatic extension, all of this, yes, all of this, you already know it. And the problem is that if you don't score a very high mark in the station and you failed one, then you might fail the macroscopy station because you didn't score enough in the other stations to compensate for the failure mark. Okay, you are allowed to fail one out of the 4 but you have to compensate. And that means that you must have done your best in the rest of this station macro. So the reason why I am putting the next the next slide in, because yes, we sample it as mega block. If you don't have a mega block in your practice, this is not my problem, okay? And this is not the examiner problem, okay? You do what we do in the United Kingdom. This is a UK exam, and we expect you to say what we do, what's our practices, okay? Basically, the epicenter of the tumor is important, and you cannot know the epicenter unless if you examine it on a mega block. So you know, is it centralized around your pancreatic duct? Is it centralized around the common bile duct? Is it centralized around your the ampulla, for example? All of this is what you see. You wanted to see if there is direct invasion to the duodenum. You wanted to see some of the circumferential margin, perineal, perivascular. So this picture of the mega block will imprint into your mind what you are going to say to the examiner, what you do not see in the specimen, but you have to say, right? There is the difficulty of this specimen, that we give you the picture, which is difficult, like that one, because a lot of you don't have that, like, what I'm going to say about this? I don't see a tumor, I don't see anything, right? But this is the idea, isn't it? I just wanted you to spell out. Actually, it is a good picture because there's nothing here to miss. You can, the imagination, you build your imagination and just go around it and talk about all of these points that we are talking about. The problem that you must be like a bullet points here, yes, because you need to move every 2.5 minutes. If you don't, they will stop you, because they will say, okay, you can stop here and we will move to the next one. So this is when the booklets comes in hand, because if you write, this is what I'm going to say, so you stick to the point and you don't bluff around, you don't keep saying the same things on and on again, like what I'm doing today in the lecture, yes? No, you say, my measurement is, okay, for every organ, you include it, you give a separate measurement, you try to measure properly, if you can, and then this is how we open the specimen, this is how we ink the specimen, this is the block this is how I'm going to cut the specimen, and these are the block that I'm going to take. Okay, so in that sequence of events, you are answering every questions, and every time you say the sequential blocks that I'm taking for the pancreas are taken to assess the maximum dimension of the pancreas, the background disease in the small and peripheral ducts, the relationship to the common bile duct, pancreatic duct, margins, duodenum, ampulla, yes, to the peripancreatic fat. All of this, you see, all of this, you have to say it. If you don't say it, then you get marked as negative. You don't score, right? And you need to be saying why I am taking this block, okay? So these are important. The next few minutes, I will just highlight into these different types of this is a distal pancreatectomy with the spleen, okay? So we tend to weigh this, okay? So this is one of the we weigh our breast specimen, we weigh our glands, like if I get a thyroid glands, parathyroid glands, if I get a spleen, I weigh it. If I get a liver, I weigh it, okay? So basically, we weigh this kind of solid organs, we like to mention the weight of it, as well as the three-dimensionality. We don't canalize the pancreatic duct, neither in the head of pancreas, or we don't cannulate it. I mean, we don't cannulate it. We don't put probes inside them, right? Because you can puncture it, or you can basically disturb the IPMN, and then you don't see the precursors of this tumor. So you need the IPMN is good to know because it gives you an idea about multifocality of the disease, as you all know. So it can give you an idea about how the rest of this pancreas might behave in the future if you, for example, get it. But you need then to understand this. The difficulty sometimes that some people face is how you orient it, but you should know that this is left, this is right, this is superior, this is inferior. You might get the splenic vessels running in the surface here, so this can be a landmark that you can also use sometimes. You have a margins on one side. You don't have any other margins, but you have circumferential surface here and lymph node and the hilum of a spleen that you need to deal with separately. So for the margins, some people might take it as a shave margin, okay? And this is what we tend to do. And then you slice it into horizontally or vertically is fine. And then you deal with your hilum to see if you see already that you might just need to take a couple of blocks from the hilum and a couple of blocks from the background spleen for completion. If you think that your tumor is more central rather than being more distal, but if your tumor is more distal here, then you might then need to extensively sample the hilum with a crochet fashions in order to see the involvement of the pancreatic hilum and the splenic parenchyma with this type of tumor. But why this is unlikely that this will come, but I just thought to give you a glimpse into this particular case. The other question that you might get stuck with in this pancreatic specimen is, for example, the grading. How do you grade this tumor? Well, we all know it's an adenocarcinoma, and I might give you in the heading already, it's an adenocarcinoma of pancreas, okay? Because it's a head of pancreas cancer. Even if I don't tell you, and I ask you, what do you think the tumor will be? You would say, based on this type of surgery, Whipple, it's usually done for a cancer in the head of pancreas, and the commonest cancer that happens in the head of pancreas, adenocarcinoma, so it's most likely adenocarcinoma. And then the question might be, okay, how do you grade it? The problem here that in the data set, and for those who do pancreatic pathology, they might know that classification well, but if you haven't read the data set, or you didn't really pay attention to it, or you don't do pancreas day to day, then you don't know that there is a grading system for the pancreas, and then there is a problem, isn't there? Yes, because you don't know that there is more into the story. Okay, it's not only about the Cinderella story, it's about Cinderella, her sisters, her stepmom, the prince. Yes, so there is a lot of things that you can put in the grading system here for this particular tumor. And then, of course, you get penalized. Imagine that it is the third question. How do you grade this tumor at this site? Yes, and you don't know that, right? Then it's becoming a problem. I know a person who hated this patient. It was a cervical cancer, and she would ask, can you tell me about how you stage this tumor? So basically, they're asking about the FIGO stage and how do you deal with it. And if you don't remember it, then you will not like that particular moment in the exam. It will not be a good thing. As you can see, I was preparing a second case to go through, but I think the second case will take a long time. and therefore we will have to kind of summarize what we have talked about today, because I am aware, of course, that we only for 1 hour and you also have a lot of other commitment to go through. So we can use the next few minutes for questions, and if you have a question, just ask me on the chat room. I have it open now in front of me, and I can see the questions and I can reply back to this in order to highlight that. As I said, I am not teaching you here how to cut a specimen. For those who are here only to learn how to cut a specimen, they will be disappointed. I'm here only to tell you that I'm here only to tell you about what you're going to do, what are the pitfall, and what are the problem that you might face in the FRCPath in that station. And I hope that this, especially for those who never been to the exam before, that they find that session useful. I never taught macro for exam before, but I hope that this is useful. So will we do gross, then short surgical? Yes, this is what you will be doing. The short will present. Let me just read the questions. Yes, we will post in the YouTube these lectures in due course. Yes, it will be available, the recording. And then what are these specimens that commonly asked? Any, right? Any specimen that you might think of might come in the exam, except maybe I wouldn't give you random biopsies, and I wouldn't give you a skin excision, because these are the things that everyone knows. But system by system, any specimen can come. We don't tend to bring liver into the questions, so into this it doesn't really come. But the things is, yes, it can come. The data set. Brain doesn't come because this is a general pathology exam, and brain is a specialty area that only get taught in a different world. So no, the doesn't come, but bone does come. Femur came previously in exams. I would say placenta, not a complicated placenta. It will be a very simple placenta if it's to enter into the exam. So it won't be anomaly placenta. It will be a straightforward placenta with the like the one that everyone sees every day. So if it is to come, it won't be like one which you will do. Mega blocks. It's used a lot in the head and neck meeting. It is in head and neck, sorry, cut up, and it's used a lot in the pancreas, and sometimes in the exantration specimen. Sometimes we use it as well in the small specimen, in the lower GI specimen that have debulking, like a bladder, also has got a rectum included, because you want to see the relationship to the sphincters, and you cannot see that unless if you do mega block. The thing is that the ear wedges, no, it doesn't come. So just so you don't panic about those, they don't come. And thyroid, you don't really need a mega block for thyroid, no, because even when because we don't leave the cancer to suffocate the patients in the UK. We usually take in a small blocks. I hardly, I'm a head and neck pathologist. I rarely take a mega block in my thyroid specimen because there is no point. You just need to assess the tumor, the capsule, things like that. So you're focusing on certain area. Spleen, because there's nothing to say anything about spleen really. Splenectomy usually taken for trauma. The things to remember for any trauma procedures is the photography. And yes, for this specimen as well, while we are talking about opening the specimen in pancreas, this is probably, if you remember, sometimes people forget, but if you remember to say it in the exam, say, I will take a photography of the specimen and for the slices. Okay, this is what we do in our practice here. After we slice the pancreas specimen, we tend to take photography into this idea. You don't need to, the circumferential margins of the specimen, it is easy. It is circumferential going from anterior to posterior. So you go in order, and anterior is anterior, posterior is posterior. It is the area that's connecting the anterior surface from the posterior surface. You have the superior mesenteric vein or the SMV groove. You don't get the vein itself. And then you get the superior mesenteric artery surface. That is the surface opposing the superior mesenteric artery. And then you have the pancreatic neck, and below it, you get the uncinate process. So these are the margins that you probably have into your specimen, and this is how you deal with it. But if you go to any anatomy book, as I said, you will realize, but in the data set as well, it is very clear there. There is no way that you will skip the data set. Okay, yes, they are hideous, they are long, but this is the UK exam. Our life in the data set, your life to pass this exam, part of it, not all of it, but part of it is in knowing your data set. But you cannot study the data set without applying it, because this is when it becomes nonsense. So if you wanted to apply, then apply on grossing straight away. We don't give courses. This is the course that we give because we do it, it's a non-profit things, and we don't do it. Yes, if you can say, but you can say that if what you are looking at is a fresh specimen, for those who are asking about molecular testing, you don't do molecular test like basically biobanking. Yes, that is what you are trying to say. Biobanking, you can mention it at the beginning. If the specimen is received fresh, and you have a biobanking facility, you may wish to sample the specimen, okay? But if you don't, then that's a different. There is e-resection is different from a wedge resection. Okay, so e-resections will have the external auditory canal margins and will have a lot of other margins. This is different from the question. The question that was asked, you get a wedge resection from the ear. E-resections is a different story, okay, because it have deep margins, it have bone margins, it have external auditory canal margins and other stuff. I will bring it one day to show you. Thanks for highlighting this. Yes, you are absolutely correct. But yes, so I think I answered most of the questions here, and the SMA groove in the lower aspect of the specimen will merge and melt with the uncinate process. So just for those who were asking these questions, I hope that this has responded to this. We will announce the next sections because it is just till we set up a certain date, but it's going to be sometimes next week. Okay, so it will be sometimes next week. So I just wanted in these sessions to give you a flavor of macro. I hope that you did find that useful. Please remember that what I said today and teach it to people. Okay, teach it to people, because this is how you give opportunities for people also to pass the exam. Okay, it's not a competition here. Okay, we all wish for everybody to pass and to get a better opportunities in life. Either you want it for your local work, you want to go and work somewhere else with it, or you work to increase your income by getting the certificates. Whatever it is, just help people as much as you can. And let's hope that it will all come to benefit us all. Thank you very much for your time and for tuning in. I hope it wasn't a waste, and we will catch up next week, and we will keep you updated. Thank you.